Welcome to the deep dive. Today we're tackling equine colic, which is a really concerning issue for anyone involved with horses.
Definitely.
It's such a broad term, right?
Yeah.
And trying to figure out what's happening, what the best course of action is, well, it can feel incredibly stressful.
It absolutely can. Our goal today really is to clarify things a bit. We're drawing from the material in Equine Colic, to cut or not to cut.
Right.
And we want to help you get a much clearer understanding of, when colic can likely be managed with medication and when surgery becomes a serious necessity.
Exactly. We've got this article here outlining the crucial parameters and the common types of colic.
Right.
And the single most important thing, the real guide here, is pain. We'll keep coming back to that.
That's absolutely right. The article really emphasizes quite unequivocally that the nature of the pain and how the horse responds to it is the key differentiator, medical versus surgical.
Okay.
So a horse whose pain isn't consistently relieved by, say, standard pain management, that's signaling a potential surgical issue. It needs prompt veterinary evaluation.
Okay, so it's not just if they're in pain, but how they're in pain and how they respond. Got it. What other indicators can help us sort of figure out if it's medical or potentially surgical?
Yeah, beyond the pain, the article points to several other really informative parameters. One crucial area is looking at lactate levels,
Lactate.
specifically comparing the lactate in the horse's bloodstream, the serum lactate, with the lactate in the peritoneal fluid.
Ah, the fluid inside the abdomen.
Exactly, that fluid within the abdominal cavity.
Interesting. So what does comparing those two actually tell us?
Well, generally speaking, if the lactate levels in both the blood and the peritoneal fluid are, pretty similar and maybe only mildly elevated, that often suggests a medical issue.
Okay.
Assuming, of course, the horse isn't severely dehydrated or dealing with endotoxemia, that systemic inflammatory response.
Right.
But, and this is the key part, if we see a significant difference where the lactate level in that peritoneal fluid is noticeably higher, much higher than in the blood, that's a really strong indication that something serious is happening locally, right there inside the abdomen. It points towards a surgical problem.
Ah, okay. So a slight overall increase might just be stress, but that big contrast inside the belly suggests a physical issue right there.
Precisely. Think of it like a localized crisis signal.
That makes a lot of sense. What about the fluid itself, the peritoneal fluid? What can its appearance, its qualities tell us?
Yeah, the qualities of the peritoneal fluid offer really valuable insights too. In medical colic, the fluid typically isn't blood-tinged or what we call serosanguineous.
Okay, not pinkish or bloody.
Right. We might see a slight increase in the protein level, maybe, but the white blood cell count is usually within a normal range.
But surgical is different.
Yes. With surgical colic, the peritoneal fluid is often serosanguineous, so it looks pinkish, or even, frankly, bloody, and we'll typically find both increased protein and a higher number of white blood cells, particularly neutrophils.
Neutrophils, those are the immune cells, right?
Exactly, the ones that rush to areas of inflammation or infection. So seeing cloudy or pinkish fluid that's packed with these inflammatory cells, that's another strong indicator you might be looking at a surgical issue.
Okay, cloudy or pinkish fluid, high protein, high neutrophils. Another warning sign.
Good.
Now, the article also mentions gastric reflux. We know that happens when things aren't moving through right. How does that fit in?
It does. Gastric reflux, the backflow of stomach contents through a nasogastric tube, it can certainly occur in medical colic.
Like in proximal enteritis.
Exactly. The article mentions proximal enteritis specifically, where the reflux often has that distinctive red-brown color and, well, a pretty foul odor.
Okay.
But the crucial factor here is the volume. The amount of reflux.
Ah, the volume.
Yeah. If we're getting a large amount, the article suggests more than about 4 liters that frequently signals a surgical obstruction, either in the small intestine or certain types of large colon obstructions or displacements.
So some reflux might be medical, but a lot of reflux points towards a blockage needing surgery.
That's a good way to put it. Volume is really key there.
Okay. What about what a vet can feel during a rectal exam? I know that's a really important part of the evaluation.
Oh, absolutely. Rectal palpation provides critical information. In medical colic, the findings can be quite variable, but typically we don't feel significant gas distension or those taut bands in the large intestine, the teniae.
Right, those tight bands.
Yeah, you usually don't feel those being really tight or thickened in a standard medical case. However, in surgical colic, it's much more common to feel a large colon that's significantly distended with gas. You might feel those really firm taniae or even loops of distended small intestine.
So it gives the vet a direct feel for potential physical problems.
Exactly, a direct sense of potential physical abnormalities inside.
And finally, the article touches on rectal temperature. Is that a reliable way to distinguish between the two, medical versus surgical?
Rectal temperature on its own is less conclusive. In medical colic, a horse might have a high temperature, a low one, or it could be perfectly normal. In surgical cases, a normal or even a low temperature is actually observed more frequently.
Huh, interesting.
So while it's definitely a piece of the overall puzzle, you always check it, it's not as direct an indicator as the horse's pain response or the lactate levels or what that peritoneal fluid looks like.
Right, so that unrelenting pain is the big alarm bell, the main one.
Mm.
But all these other factors, the lactate difference, the fluid quality, the reflux volume, what you feel, they help build a clearer, more complete picture.
Precisely. It's about putting all those pieces together.
Okay, now the article goes into some specific types of colic. Let's start with the medical side. First one mentioned is proximal enteritis. What can you tell us about that one?
Right, proximal enteritis. It primarily affects the small intestine. And as the article highlights, the classic signs are often, well, a milder form of colic or even just depression.
So maybe not thrashing around.
Not necessarily. They might seem more subdued, depressed.
Yeah.
Plus, often a fever and that copious red-brown, foul-smelling nasogastric reflux we mentioned.
Okay.
It's interesting, these horses often appear more kind of off or depressed than showing that intense abdominal pain, almost like they're saying, I just don't feel right, rather than violently reacting to gut pain.
So how do vets diagnose it then if the pain isn't always dramatic?
Diagnosis is based on that combination of clinical signs plus what we see on ultrasound.
Ultrasound.
Yeah, typically the ultrasound will show a thickened wall in the small intestine, and it won't be moving as actively as it should. Maybe it looks a bit distended. And like we talked about, the peritoneal fluid usually shows that elevated protein level, but a normal white blood cell count.
Okay. And the management. How is proximal enteritis typically treated?
Treatment really focuses on supportive care. So intravenous fluids are crucial to combat dehydration, pain relief medications, naturally, and regular decompression of the stomach with that nasogastric tube to relieve the pressure from the reflux.
Keep emptying the stomach.
Exactly. Sometimes surgical decompression might even be considered, but mostly it's medical management, and it's also important to take preventative measures against laminitis.
Right, the hoof issue. That can be a secondary complication.
Yes, it can sometimes develop. So laminitis prophylaxis is key.
And prevention. Is there anything horse owners can do to stop proximal enteritis from happening?
Unfortunately, the article points out that the exact cause is still unknown, which means specific prevention strategies are also, well, unknown at this time. It seems to be more common in the eastern U.S. and Europe, which is an interesting pattern, but yeah, the underlying reason is still a bit of a mystery.
Huh. Fascinating, but frustrating that the cause is elusive. That lack of prevention really highlights how critical early detection based on those signs becomes.
It really does.
Okay, next, medical colic. Large colon impaction. That sounds pretty straightforward, like a blockage in the large intestine.
Exactly, a blockage. And the typical signs for this one are usually mild, intermittent episodes of colic. Often, the horse's overall physical exam seems relatively normal between episodes.
So they might seem okay, then colicky, then okay again.
Kind of, yeah. Mild, comes and goes. The key to diagnosis in these cases is the vet being able to physically feel that impaction during the rectal examination.
So the vet can actually palpate the blockage. How do you treat it?
Treatment usually involves giving fluids and laxatives directly into the horse's digestive tract, usually through a nasogastric tube.
What kind of laxatives?
Things like magnesium sulfate, dioctyl sodium succinate, mineral oil are common. Pain relievers are given as needed, of course. And sometimes IV fluids are also necessary just to keep them hydrated.
What about sand impactions? Are they treated differently?
Yes, for sand impactions, psyllium is a really crucial part of the treatment. It helps bulk up and move the sand through. And, in some pretty rare or stubborn cases, surgery might even be required for impactions.
And prevention. What can owners do to try and prevent these large colon impactions?
Prevention really boils down to good, consistent horse management.
Like what?
Ensuring the horse has regular dental care so they can chew their food properly, maintaining a good parasite control program, providing consistent access to fresh, clean water, and feeding good quality forage, good quality hay.
Basically the fundamentals of good horse keeping.
Pretty much. The basics done well.
Are there any Interesting turls about large colon impactions, specific spots or anything?
Yes, the article points out the most common locations are the pelvic flexure, the transverse colon, and the base of the cecum. Those
Mm.
are kind of natural narrowing points.
Okay.
It also mentions that impactions specifically in the cecum have been linked to a sudden decrease in a horse's activity level, like if they suddenly go on stall rest.
Oh, okay.
And as we touched on for sand impactions, radiography taking x-rays can be really helpful in diagnosing those.
Good to know. Okay, finally, for the medical colics, we have spasmodic or tympanic colic. That sounds a bit more general. Gas colic, maybe.
You're right. Spasmodic colic, often called gas colic or tympanic colic, it's characterized by a sudden onset of colic that can range actually from mild to quite severe.
Okay.
The horse's heart rate might be normal or maybe slightly elevated. Their mucous membranes usually look healthy, pink, and moist. And typically the gut sounds, the noises you hear with a stethoscope, are minimal.
Fewer gut sounds.
Often, yeah. And interestingly, the article notes this is actually the most common cause of colic overall.
Really? The most common? Huh. So, if there aren't specific physical findings, like an impaction, how do vets diagnose this type?
Diagnosis relies quite a bit on the overall presentation, how the horse looks and acts. Also, the lack of significant findings on rectal palpation or when passing a stomach tube.
So ruling other things out partly.
Exactly. Plus, the fact that the horse is generally systemically stable, they're not going into shock or anything. And importantly, they often show a positive response to the initial medical treatment. They get better with some pain relief and maybe a sedative.
And how is it typically treated?
Treatment usually involves pain relievers, maybe some sedatives to help the horse relax, and antispasmodic medications like Buscopan can be really helpful.
Okay.
And similar to treating impactions, sometimes enteral fluids and laxatives might also be administered depending on the case.
And prevention for spasmodic colic, is it similar to impactions?
Yes, prevention again really emphasizes consistent management practices. Maintaining a consistent diet and feeding schedule is important. Regular dental care, again, and keeping up with an effective parasite control program. Consistency is key.
Okay, that gives us a solid understanding of the main medical colics. Now, let's shift our focus to the surgical ones. These sound more serious. The first one listed is large colon volvulus. That sounds very bad.
It is indeed very serious. Large colon volvulus involves a twisting of the large intestine on itself.
The twist.
Yes. And the hallmark signs are acute, severe pain, often the kind that just doesn't respond to standard pain relief. Plus, significant abdominal distension, you can often see the belly looks bloated, and a noticeably elevated heart rate, usually very high.
And they get sick quickly.
Depending on how long it's been twisted and how much the blood supply is compromised, yes, they can show varying degrees of overall systemic distress, getting shocky.
How is a large colon volvulus diagnosed?
Diagnosis is based on that clinical picture, the severe pain, the distension, the high heart rate, plus feeling an extremely gas-filled intestine upon rectal palpation. It feels like a big, tight balloon inside. And ultrasound findings will often reveal a thickened wall throughout the large colon because of the compromised blood flow and distension.
And the treatment? I mean, surgery seems like the only option here.
Yes, absolutely. Surgery is required to correct the volvulus. This involves untwisting the colon, and sometimes, if the tissue has been damaged beyond repair from lack of blood supply, removing a portion of the colon or resection.
And the prognosis?
Unfortunately, the article notes that the prognosis is generally guarded. It's a very serious condition.
That's tough. And prevention. Can anything be done?
Similar to proximal enteritis, the specific causes and therefore prevention strategies for large colon volvulus are not well understood at this time, which again just underscores how critical it is to recognize those signs that scream surgical emergency.
Right. That immediate recognition is vital. Okay, the next surgical colic is small intestinal incarceration or strangulation. That also sounds incredibly concerning.
It is. This happens when a piece of the small intestine gets trapped somewhere it shouldn't be, or its blood supply gets cut off, strangulated.
Trapped or choked off.
Exactly. The classic signs here are progressively worsening pain, often a large volume of nasogastric reflux coming back up the tube, and a decline in the horse's overall metabolic status. They start to get dehydrated and develop electrolyte imbalances.
What are the key indicators that help diagnose this specific type?
Well, on rectal palpation and ultrasound, you might be able to feel or see distended loops of small intestine, which normally you wouldn't feel easily. The nasogastric reflex, as I said, is often copious, lots of it, and frequently serosanguineous.
Bloody reflux again.
Yes. And, back to our earlier point, the peritoneal fluid will often show that significantly elevated lactate level. That big difference between peritoneal fluid and blood lactate is a strong clue here.
And treatment is also surgical, I'm guessing.
Absolutely. Surgery is necessary to find and release the trapped or strangulated portion of the intestine. And sometimes, just like with the volvulus, a section of the small intestine may need to be removed if it's no longer viable, if the tissue has died.
Is there anything linked to prevention here?
It's generally challenging to prevent, but the article does mention one potential link: reducing crib biting behavior.
Crib biting, how does that connect?
It might decrease the risk of one specific type of incarceration called epiploic foramen entrapment, where the intestine gets stuck in a natural opening near the liver. Cribbing is thought by some to alter pressures within the abdomen.
Huh, that's an interesting potential connection.
Yep.
Are there other key facts about these small intestinal issues, things that cause them?
Yes, the article highlights that pedunculated lipomas, these are fatty tumors on a stalk kind of hanging down inside the abdomen, are a relatively common cause of strangulation.
Especially in certain horses.
Particularly in older, often somewhat obese horses, that stalk can wrap around a piece of intestine and cut off the blood supply.
Wow.
And these incarcerations, these trappings, they can happen in various places. That epiploic foramen we mentioned, through tears in the mesentery, the membrane that holds the intestines, or even through inguinal rings or umbilical openings. So a number of ways the small intestine can get into trouble.
A lot of potential anatomical pitfalls in there.
Okay.
The final surgical colic we need to cover is large colon displacement. I see it's broken down into left dorsal displacement and right dorsal displacement. What's the basic idea here?
Both involve the large colon moving from its normal position in the abdomen, but the location is different.
Okay.
In left dorsal displacement, or LDD, the colon moves upwards and gets trapped over the nephrosplenic ligament. That's a ligament running between the left kidney and the spleen.
Trapped over the ligament.
Got it.
And right dorsal displacement.
In right dorsal displacement, or RDD, the colon moves over to the right side of the abdomen, often rotating and becoming distended with gas.
And the signs. Are they similar for the both?
The initial signs can be somewhat similar, yeah, often starting with mild pain, then becoming progressively worse. You might see abdominal distension or maybe recurrent episodes of colic that keep coming back, and usually a gradual decline in their metabolic status. They get dehydrated slowly.
So how do vets tell the difference between a left and a right displacement?
Rectal palpation is really key again. With an LDD, the vet typically can't feel that normal space between the kidney and spleen, the nephrosplenic space, because the colon is sitting in it.
Blocked by the colon.
Exactly. And on ultrasound, the left kidney might be hidden by the colon, and the spleen might appear pushed downwards or forwards.
And for the RDD?
With an RDD, the vet might feel those tight taenia, those bands, of the colon in an abnormal position over towards the right side, near the base of the cecum. And ultrasound might show the blood vessels that supply the colon, the mesenteric vessels, in an unusual location on the right side.
Okay, so palpation and ultrasound help pinpoint the location. And the treatment approaches can differ too, right?
Yes, they can. For LDD, treatment might start non-surgically. Sometimes giving a drug called phenylephrine, which can help shrink the spleen, followed by light exercise like lunging, can allow the colon to fall back into place.
Interesting.
Sometimes simply rolling the horse carefully under general anesthesia can resolve it. Or surgery is also a definitive treatment option to physically put it back.
And for the RDD, is rolling an option?
Rolling isn't typically used for RDD. Initial management for RDD often involves supportive care, intravenous fluids, withholding feed, and giving pain relievers. Sometimes with just time and supportive care, it might resolve on its own. But surgery is frequently necessary if the pain gets worse or the horse's overall condition deteriorates.
So RDD might need surgery more often than LDD?
Often, yes, though LDD can certainly require surgery too.
Are there any preventative measures for these displacements?
For LDD, yes. The article mentions a surgical procedure called nephrosplenic space ablation. This basically closes off that space between the kidney and spleen so the colon can't get trapped there again.
Makes sense. What about RDD?
Unfortunately, the prevention of right dorsal displacement is not currently understood. There's no specific procedure like the ablation for LDD. The article also offers an interesting point about why this happens. The large colon has relatively limited attachments holding it in place within the abdomen compared to other organs.
So it's just more prone to moving around.
Exactly. It makes it inherently more susceptible to these kinds of movements and displacements. It's really a testament to the complexity of the horse's internal anatomy.
That really emphasizes just how intricate and maybe a bit precarious the equine digestive system is. So as we wrap up this deep dive, what's the single most crucial thing for you, the listener, to take away from all this?
I think the absolute most critical thing to remember, the main takeaway, is that pain, specifically pain that doesn't respond adequately to appropriate medication, is a major, major red flag for surgical
That
colic.
unresponsive pain.
Yes, while carefully observing all the other clinical signs we've discussed, changes in lactate, the look of the peritoneal fluid, the amount of reflux, the rectal findings, all that is certainly important for the vet.
Right.
But that persistent, unyielding pain, that should prompt immediate veterinary attention and a serious consideration of surgical intervention. That's the alarm bell you really cannot ignore.
Absolutely. So by having a better grasp of these key differences, the signs for medical versus surgical, and the specifics of these common types of colic, you, our listener, are now hopefully far better equipped to understand this often very stressful aspect of horse ownership or care.
Definitely. And this brings up a really important question, maybe something to think about further. Given the significant gaps in our understanding of how to prevent many of these surgical colics, the volvulus, the RDD, many strangulations.
Yeah, the prevention is often unknown.
Exactly. So, what avenues of further research or maybe innovative management strategies might hold the greatest promise for significantly improving the welfare of our horses? How can we reduce the incidence of these critical, often life-threatening conditions? It's definitely an area where ongoing investigation is absolutely crucial.
A great thought to end on.
Mhm.
Where does the future research need to go to better protect horses from these surgical emergencies? Definitely something to keep an eye on.